Hi, on behalf of the UNC Health Foundation, I want to welcome you to this afternoon's webinar on women's health and specifically how to protect from and treat pelvic pain. My name is Martin Baucom, and I'm Vice President of Development for the Foundation, which secures private funding to support research, patient care, and medical education at UNC Health and the School of Medicine. I'll be your host for the first section of today's event, and then I'll turn things over to my talented colleague, Jody Gisser, who's Director of Development for Women's Health. So the Foundation has, for the last couple of years, organized a series of events focused on the impact of research and care and the ways that philanthropy has forged that impact. So early on in the pandemic, we transitioned to doing these events virtually, like everybody else had to transition. And we've really been pleased with the rate of participation among our supporters and others who are interested in the work we do and the research-informed care that UNC Health provides. In fact, I think the last in-person thing that we did together was related to this very topic. And it was maybe a few days, but it had to have been early March, right? So it was probably the last dangerous thing that we didn't know was so dangerous. Anyway, all of us have made it this far. And first, I'd like to get started by introducing our terrific speakers for the event. So first up is Dr. Aaron Carey, who's Assistant Professor and Division Director of Minimally Invasive Gynecologic Surgery. Dr. Carey is a fellowship-trained minimally invasive gynecologic surgeon and board-certified obstetrics and gynecology physician. She attended medical school at the University of Missouri, Kansas City, completed her residency at the Mayo Clinic in Rochester, Minnesota, and fellowship subspecialty training at UNC. While in fellowship, she earned a Master's of Science in Clinical Research at the Gillings School of Global Public Health, and stayed on to complete an additional year of training in female pelvic pain disorders with pain medicine at UNC. She treats the full spectrum of gynecologic, surgical, and pelvic pain issues, including endometriosis care, excision surgery for endometriosis pain and infertility, Escher-related pain, transgender affirming surgery, and the management of complex pelvic and vulvar pain disorders. So her goal is to work with patients using a shared medical decision-making model to collectively create a medical and surgical plan that is deeply aligned with the patient's personal treatment goals, and of course supported by the medical literature and best practice guidelines. So when not doing all of this wonderful stuff and providing all this great medical care or chasing after her 3 young sons, Dr. Carey enjoys trail running, mountain biking, and cooking Southern comfort food. So that'll be something to look forward to in a couple hours. Also with us today is Dr. Michelle Louie, who's Medical Director of Gynecology at our clinic in Hillsborough and Assistant Professor in the School of Medicine. Dr. Louie is a fellowship-trained, I'm going to say this again, minimally invasive gynecologic surgeon and board certified also in obstetrics and gynecology. So she attended medical school at the George Washington University and completed a residency at McGee Women's Hospital in Pittsburgh and fellowship subspecialty training here at UNC. She treats the full scope of gynecologic, surgical, and pelvic pain issues, including fibroids, endometriosis, heavy or irregular bleeding, and Escher-related pain. Her special interests are fibroid care and ensuring all patients have access to minimally invasive surgery. A fun fact about Dr. Louie, she's originally from New York and has an older brother who is a pilot in the US Air Force. So welcome to both of you. Thank you so much for joining us tonight. As we talked a little bit, the life has changed for everybody in the past year. And so, throughout all of these impact series and other events we've done, we like to start by asking our expert participants to share some personal reflections. How has life changed for you? How has it changed the care you provide, the research you conduct? So we'll start with Dr. Carey.
Well, thank you for those wonderful introductions. I can't see who the participants are. I'm sure that many of you are some of my patients, and I'm really grateful that you're here. I think that many of you also know that our care has changed this last year, as you alluded to, Martin. So we are providing a significant amount of our gynecologic care virtually. And when they came to us and said, do you want to do virtual visits, I thought it was the most ridiculous thing I'd ever heard. I was like, that's just not possible. And the reality is it's really been transformative for our group, for our patients. We've been able to, I think we've been able to add clinics and see people even, at closer intervals than in-person clinics, just because we don't have to secure space and we can do it in a way. A lot of our patients travel a long distance as well. So I just think that is one of the coolest things that I've been able to participate in. So out of the darkness of COVID, we've had like this really great way to provide care to our patients. And I was also surprised at how much gynecology you could do virtually. I mean, I've just felt really lucky. I know many of you have taken these virtual visits like with both of us in the comforts of our home. And I think that there's like a special, like personal, like almost intimacy, right? To be in each other's safe spaces when we talk about important things. But it's been, what a year.
Dr. Louie, how about you? Thank you for sharing that, Dr. Carey.
Yeah, I would just, again, like to thank Martin for that kind introduction and welcome all of the guests here. It's a wonderful part to really take something like this, which we wouldn't ordinarily be able to do for so many people, and talk about something that most people find kind of private and intimate, and really do it with all of us together. And I hope that, throughout this presentation, it becomes clear that you're not alone. And if you really haven't felt that way, you can look at the other 34 participants on the call today and just know that there are so many other people who are experiencing similar symptoms. And, to echo Dr. Carey's sentiment that, while the past year has been full of surprises and difficulties for lots of us, both professionally and personally, I would say that one of the other benefits of this pandemic has been how we have changed the way that we do presentations and how we do conferences, and to be able to put together a meeting like this, I think is really incredible, not only, in order to give patients and other people information about a topic that can seem kind of taboo or private, but also for a way for all of us who are living across North Carolina and maybe in other states to be able to get together. So I would just like to thank the organizers of the event and really welcome you guys to the new age of pelvic health.
Great. Well, thank you for that personal reflection. And with that, I think we're, Dr. Louie, you're up first to make your remarks and share a presentation. Thank you.
All right. Can I get a thumbs up, Martin, if you can see that? Thank you. Okay, well, without further ado, we'll jump into our first topic here, which is pelvic floor health. And what I would like to discuss with you all today is pelvic floor muscle spasm. There's a lot of myths about pelvic floor spasm, about what it is and about what it isn't. So we are just going to level set the whole group and first start off with what is the pelvic floor. What I tell patients in clinic, and for those of you out there who've heard this, I'm sorry, but I'll just make sure the rest of the group is aware that the pelvic floor is like a hammock or a sling of muscles that holds all of our insides in. And so it is a sling that wraps around the vagina. It also will wrap around the rectum and the neck of the bladder. And this is important anatomically just to understand how these other organs can be impacted when the pelvic floor misbehaves. So the pelvic floor is really not just one individual muscle, but it actually is a group of muscles that make up this whole supportive area. And you can see on the photo to the right how it really holds up not only the uterus across the vagina, but also the bladder and the rectum here. It connects to the spine in your back and to your pubic bone in the front, and then from each hip on side to side. So it really forms like this large bowl that's sort of holding all the insides in. When the pelvic floor misbehaves, it can be really painful, and we describe that as a pelvic floor spasm. The official medical terminology that you might see in our notes is pelvic floor tension myalgia. It is diagnosed or felt by patients as a long-term or long-standing pain that can radiate to many different areas: the front side of your abdomen, your back, your hips, the rectal area or the anal area, as well as the vagina. And it's really when these pelvic floor muscles, when they contract, they are very strong and can create a really intense discomfort. A lot of patients ask me why this happens, and really the bottom line is that we don't know. There are a lot of theories about predisposing factors, visceral pain syndromes, which we'll talk more about later. Some people believe it has to do with the number of pregnancies you've had or how they were delivered. Certainly there are some people who believe that larger deliveries or forceps-assisted deliveries may make women more prone to pelvic floor issues. We know that certain biomechanical differences can predispose patients to having pelvic floor spasms. So chronic lower back pain, hip dysplasias, scoliosis may impact the function of your pelvic floor because your pelvic floor is having to compensate for the weakness or dysfunction in the back or abdominal wall muscles. Overuse injuries are common in people who have very active lifestyles, but also jobs that require a lot of heavy lifting. Repetitive vaginal or bladder infections is often reported by patients, and we don't know if it's necessarily the bacterial infection itself or just sort of the constant firing of those pelvic floor nerves and muscles. And then most commonly, people don't describe any sort of trauma or abnormality at all, but do report a history of just sort of stress. And that kind of baseline stress that we all can experience can be demonstrated in the pelvic floor. So just like a lot of times when we're really focusing, our jaws are a little bit tense, our shoulders are a little bit tense, we can also be tense in the pelvic floor. And so all of these things in combination probably can trigger the pelvic floor spasm for some people. And for some people, it's just a transitory trigger. But for other people, it can be more of a chronic or long-term process that can last for years or decades. And the reason why we're talking about this today, when we're talking about sexual health, is that oftentimes pelvic floor spasm can result in pain with intercourse. So this is one of those things that is very common, is very treatable, but is very underdiagnosed. And a lot of times when women go to their doctors and say that they have pain with intercourse, they're told, well, just use a lubricant or try a new position or go on a date night. As if, we haven't already tried all of those things, right? And so the pelvic floor is just an often ignored and undertreated part of our bodies. And it's not, it's just because it's not something that's seen on an ultrasound. It's not something that you can see on a CT scan. The function that we're talking about is not something that you can visibly diagnose with a blood test or with an imaging study. But when it misbehaves, it causes a lot of pain that can occur with sex or without sex, but oftentimes it prevents people from doing the kind of things that they really want to be doing. So we'll just move into now a couple common questions that I get in the office or things that I've heard that I would really like to touch on. And the first is, a lot of people say, well, if you're saying that this is just a pelvic floor spasm, does it mean that it's no big deal? I just have to live with it? Does it mean that this is all in my head, that I'm just kind of crazy? And, obviously my first response is, of course not. It is not in your head. It's a real thing. The pelvic floor is a group of very hardworking muscles, and they can spasm. And again, it's not something that you're going to see on an imaging study. So when you go to the emergency room because of pain, it's not something that's going to be diagnosed by an emergency room physician, because they're not going to do the kind of exam that we do in our office. And they're not going to necessarily focus on those parts of your history in the emergency room. So it is a real thing. It is something that has a diagnosis, it has a treatment. And so the first thing I'd like to say is that it is not something that is no big deal. We recognize that it can significantly impact your quality of life, and that's why we're here. Another common question is, does this mean I don't have, insert whatever medical problem that you were told that you had before? So, commonly we get patients who say, well, I was told I had a cyst, or I was told I have prolapse, told my bladder was dropping, and that's why I have this sensation. And, it doesn't mean that you don't. it may mean that you do have one of those other things. So very commonly, there can be a lot of other things that can occur in the pelvis. We look for other sources of pain that may be contributing to the pain that you're having with sex or the pain that you're having in between intercourse episodes. And it doesn't mean that you don't have those things. It just means that you may also have pelvic floor spasm. But I would like to mention that a lot of times the things that we see on imaging studies aren't necessarily the cause for your pain. So when you go to an emergency room or when you go to a doctor's office, the first thing they're going to do is an ultrasound or some kind of, imaging study. And they may find a cyst, they may find fibroids, they may find that you have prolapse. And oftentimes we associate those abnormalities with the reason why we're having pain. But very frequently, just because those things are there doesn't mean that they're the cause for the pain that you're having with sex or the pain that you're having in between episodes. It may be that you have a cyst and you also have pelvic floor spasm. It may be that you have a cyst and it's completely by accident that they saw it on your ultrasound or on your CT scan. So, that's just important to bring up with your doctor that, I was told I had these other things, what does that really mean? And we can help put that into context for you. The other thing is that very commonly pelvic floor spasm overlaps with a lot of other pain conditions. People frequently have IBS or endometriosis, and they may also have pelvic floor spasm. And that's because all of these conditions fall under what we call pain or central pain disorders. And it means if you have one of them, you're more likely to have another one of them. So people with fibromyalgia are more likely to have irritable bowel syndrome, and people who have irritable bowel syndrome are more likely to have pelvic floor spasm. So it's not that you can't have more than one condition, it's actually the opposite. If you have one, you're more likely to have the other. Another common question that I get, or another common sensation that women report to me, is that it feels like something is falling out, or I was told that I have prolapse. Prolapse is when the pelvic organs actually descend into or protrude into the vagina. If you've had a hysterectomy, it may not be the uterus, it may be your bladder or your rectum that's protruding into the vagina. So depending on what part of pelvic support is lacking, different organs can push their way into the vagina, and it can be diagnosed as prolapse. But prolapse is not often painful. In fact, the entire uterus can involute and come out of the vagina and be visible between the legs and still not be painful. It's really the pelvic floor muscles that are spasming that produce the pain that can often co-occur with prolapse. So it's not the prolapse itself, it's still the pelvic floor muscle spasming that is painful during intercourse. So you may also have prolapse, but that may not be the problem. And we see that not infrequently, that people have surgery for prolapse, or they say, I was given a pessary and my pain is still the same. And that's because treating the prolapse is not treating the pelvic floor spasm. And that's why the pain doesn't get better. Oftentimes people describe the pain with pelvic floor spasm as it feels like there's a ball in the vagina, it feels like something is falling out, it feels like I'm crowning, it feels like I'm pushing something out, or I'm giving birth again. And that's just because those pelvic floor muscles are contracting and spasming, and that gives us the same sensation as sitting on something or delivering a baby. And that's because those same muscles are firing, right? So does that mean there's nothing I can do? No, our whole job, Dr. Carey and I spend most of our days telling patients that there is a lot of things that you can do, and we are here to help. The first thing that we always tell people is that, the good news is you don't need a surgery. You don't need a bladder lift. You don't need a hysterectomy. Those things won't help with your pain, and no one wants a surgery if they don't have to get one. So the good news is that this is not treated with any kind of procedure. There are a lot of things that people can do at home. And most of the time, by the time you've seen us in the office, you've already tried a lot of these things. So we respect the fact that you've tried the heating pad, you've tried ibuprofen, you've tried ice, and those things haven't really helped. So what we offer are some more advanced treatments. Oftentimes we refer patients to physical therapy, which may include some hands-on work. It may also include some other additional treatments like vaginal dilators or dry needling, or even using a TENS unit. Sometimes we write prescriptions for muscle relaxants. There are many different kinds of muscle relaxants. So a lot of times patients will say, well, I tried one and it didn't work, or I tried one and it made me really tired. And it's just because we need to find the right medication for you. And we don't always know what that's going to be before we try it. So sometimes we'll have to try a couple different options before we get the right medication for you. And then if those things don't work, we can always move to other treatments like injections or even Botox treatments. And those are things that we talk about in the office for people who continue to have pain despite these more conventional treatments. The other thing that people ask me is, can I just do physical therapy on my own? Or, I tried doing pelvic floor yoga and it didn't work. So pelvic floor yoga is great. I recommend it for lots of people who really just need to open up the pelvic floor and improve their pelvic health generally. So that is something that is easily done at home to maintain or sort of prevent pelvic floor spasm. But once you have really severe pelvic floor spasm, so much so that you're not able to have sex comfortably, doing physical therapy at home probably won't be enough. And you may often benefit from going to an actual physical therapist where they can do hands-on exercises, both externally or internally, if you're comfortable with that. They can also do other things like dry needling or using a TENS unit, as I mentioned before, which help to activate the muscles differently and can release that spasm. They can also teach you to use vaginal wands or dilators at home in a more deliberate way. So oftentimes when you're trying to do these things on your own, you may not really know which muscles are the problem or which muscles are contributing most to your symptoms. So having a licensed physical therapist is really, really helpful for gaining that extra anatomical knowledge about your own body, and having an expert really give you exercises that are specific to you. They can also help you if you have bladder issues or issues with constipation. They can give you additional exercises for better bladder function or better bowel emptying. So being open with your physical therapist and sort of letting them know what your goals are, where you're having your specific issues, can give you even better results. And then just, sort of as a reminder, there are two different kinds of physical therapy for the pelvic floor. There's the one kind, which is for people who do have prolapse, who have leakage of urine, and they're trying to tighten the muscles in the pelvic floor. They're trying to increase their pelvic tone and reduce that prolapse. For patients who are having pelvic floor spasm, that kind of physical therapy is the opposite of what we're trying to achieve, because we're trying to get relaxation, we're trying to get strength, but we're also trying to reduce spasm. So you really have to make sure that you're going to the right kind of physical therapy and not just trying to DIY on YouTube videos. It's okay to do that once you've had your initial consultation with a doctor, with a physical therapist. Certainly supplementing those exercises with homework is great. But just be sure that we're doing the right kind of exercises. So if you're not just having pain with sex, if you're having pain in your hips or your back or your abdomen, that's a really common sign that you may have other areas of your core involved. So the pelvic floor is the bottom part of your core. And the other part of your core is, of course, your abs in the front, your back muscles, and all the way up to your diaphragm. So a lot of patients will say, it's not just pain in the vaginal area. I have pain in my back, I have pain in my hips, I have pain in my belly. And that's because the pelvic floor really is connected to all of those areas. So if the pelvic floor is spasming, it's going to pull on the back, it's going to pull on the abdominal muscles, and that is going to be a referred source of pain as well. So it's important, again, to just let us know that those areas are also an area of focus, and we can address that as well. It's okay if you don't want to take medications. It's okay if you tried physical therapy or any kind of other treatments and they didn't work. There are a lot of other things that we can do, either prescription-wise or non-prescription-wise, that can be helpful. So don't give up. It's okay if you don't want to use medications. Just let us know what your goals or preferences are, and we can try to work with you to do the best we can to give back quality of life, but also within the parameters of what makes you feel comfortable. As far as non-pharmacologic or prescription medications, there are a lot of things that can be really helpful. A lot of people benefit from doing this anti-inflammatory diet. We have a handout in our office that we like to give out that can be helpful, but very briefly, it's sticking to whole foods, reducing processed or highly refined foods, steering away from red meat or dairy, which can be a little bit more inflammatory. We can definitely talk more about the details, but a lot of patients find that cutting out specific things like alcohol or carbohydrates can be helpful, and focusing more on whole grains rather than processed grains. So there are small tweaks that we can make that can be beneficial. Sleep and exercise are super important for just overall health, and the pelvic floor is no different. And then some of these other adjunctive treatments like cognitive behavioral therapy, acupuncture or chiropractic care, massage therapy, meditation or mindfulness can be really helpful in reducing some of that tone or tension in the pelvic floor that often gets really elevated and can contribute to worsening pain or spasm, especially during intercourse when we are more likely to be tense. And so we can talk more about these in the office. They're really helpful for other people. And the good news is they don't have any side effects. If you don't like it or they don't work, that's okay. You probably won't have any side effects from them. The worst thing that could happen is that they don't work and we can still move on to other things. So I will just end here to just say that there are a lot of other resources that we have that we will make available to you guys. We will both be available for questions at the end. So without further ado, I will switch to my colleague, Dr. Carey. And if you have any questions, please put them in the chat and both of us will be back at the end.
Thank you, Dr. Louie. You're hard to follow. Can we do this over so I can go first? All right, so it's the reason we're asked to kind of put our heads together about the things that we wanted to talk about. We really wanted to talk about the things that were most common with the patients that we see in our clinical practice. And we see a lot of overlap with patients who have pelvic floor muscle spasm, who are also peri and postmenopausal and have low estrogen in the vagina and have symptoms associated with that. So we really thought these paired well together. So we can go to the next slide. So I'm going to just talk a little bit about genitourinary syndrome of menopause. So this is the new term for the old term called vulvovaginal atrophy or genital atrophy. And it's really, they packaged it this way because it really is a syndrome, right? You have vaginal dryness, burning, urinary symptoms, and it affects a lot of women. So there are, what I have here kind of just globally more than 50%. Some studies say almost 90% of women have some symptoms of GSM. And what's really interesting is it has a pretty solid prevalence in even younger women. So women in their 40s, about 20% may have symptoms connected to lower estrogen levels in the vagina. And, despite this super high prevalence and all of these issues that come with it, it's still underdiagnosed, undertreated. Most women don't even discuss their symptoms with a gynecologist because, for a variety of reasons. One, embarrassment. They may think it's just a natural part of aging, or they're uncomfortable talking about it. So there is treatment that's available for this syndrome, and we can certainly talk about that, but women tend to do a pretty good job of starting that process by self-medicating, but it may not be enough. So can we go to the next slide? How does low estrogen present in the vagina and vulva? And so we see that this is kind of, as I mentioned earlier, it's a vaginal dryness, vulvar dryness, so dryness even on the skin on the outside, burning, pain with intercourse. Even with some of these symptoms, we'll see a kind of a refractory decrease or less desire to have intercourse because it just doesn't feel good. And that's really common. It's a chronic condition and it can worsen after menopause. I think this is something people also don't expect. Like hot flushes tend to be kind of time limited. So even if you have some hormonal support or not, it tends to get better. But what we see with GSM is that if you don't treat it, then the symptoms can actually become worse. That's not fair. So how does low estrogen, so I think the biggest thing is like, what does this look like? And I can tell you on like a histologic level, it really is pretty significant. So on the next slide, we can see here, and I know that this has probably taken us all back to like high school histology, but I think this is really a cool slide, because you see here, I don't know if you can see, but the level of thickness here in this top layer, this is a vaginal epithelium. These are little tiny biopsies. And over here on the far left, you see in the A box, you see a well estrogenized vagina. So it is thick, healthy. It has good circulation. It has, it's really rich in glycogen. So those are these cells that kind of have all this really nice clear cytoplasm around it that that kind of help beef up the tissue. And then you see in B, it's a little thinner, right? It's just starting to, and this may be in those first few years after we go through kind of perimenopause or menopause. And then you see in C, you see this really flattened, thin tissue. You don't see any of those little like ridges, those big like soft waves underneath it. And here is a really atrophic vagina. And the glycogen I'm talking about, it is a reduction in this causes issues because it also results in a reduction of the good bacteria in the vagina, the lactobacilli. And so we see with lower good bacteria, women may have, in addition to that dryness, irritation, rawness, they may actually have an increase of infections in the vagina or anaerobic bacteria that could lead to like bacterial vaginosis. The vagina, when it has less estrogen, just has fewer secretions, which we feel clinically, but it's also more vulnerable to tears. And you can see that just through this picture. It's thinner, it's going to be more likely to tear, and more likely to be irritated and tear with any manipulation of the vagina. So intercourse. Next slide. What treatments are available? Like I told you what the problem is. So how do we kind of identify things that may be helpful? So on the next slide, I have to kind of laugh at the lubrication slide. So to lube or not to lube, and lubrication's kind of funny because I think I love the term that Dr. Louie used earlier, the taboo. Like lubricants are taboo, or at least they used to be. And we see that or for a long time it was really, they were reserved for women who were having perimenopausal and menopausal changes of the vagina, and you only used it if something was wrong. But actually, so we've actually seen a real big change of this. So in women under 30, so women who don't have any reason to have low estrogen of the vagina, personal lubricants have really gone through the roof. So younger women, those without sexual dysfunction, without vaginal dryness or pain with intercourse, are actually more likely to use lubricants to enhance the sexual experience in a normal reproductive age sex. So just at baseline, it is now much more acceptable and welcome to make sex more comfortable, fun, pleasurable. It's more accepted by the partner. And it is used kind of in all stages of sexual intercourse, from early play, foreplay, even solo or non-partnered sex. So it's kind of stratifies all of the things. And so I think that what the good thing about that is that it has increased the number of products that are available. Like it's not just, you don't just go to the little corner of the drugstore and pick out those 2 that are commercially available, but there's a huge variety that are available. And part of that's been pushed by younger women using it. But part of that is as we age, we also have really been more vocal that we need things that work for our vaginas that are a little different through age. I'm going to talk about some of these differences because I think it's that important. And so certainly for the reason I bring this up is because lubrication, and I'm also going to talk about vaginal moisturizers, are really the first line treatments for some of these symptoms, and they can certainly be paired with other symptoms, or other treatments. Next slide. I know I feel like this talk is pretty sciencey, but I think some of it's important to understand why lubricants and vaginal moisturizers work and why they may not be great for a vagina that is thinner. And so I'm going to talk a little bit about the osmolality of lubricants and moisturizers. And so basically, just at its baseline, osmolality is the measure of how much one substance is dissolved in another substance. And so I'm using this example. So really salty water, if you're making salt water, if you would dissolve a lot of salt into the water, it has higher osmolality than something that just has a small amount of salt. And the reason that's important, and we can go to the next slide, is that in lubricants, so when you have greater amount of product dissolved in these water-based or silicone-based lubricants, it increases the osmolality of the lubricant. And the problem with that is high osmolality lubricants are more likely to cause irritation of the vagina, tissue damage. It can actually reduce how much fluid is released. So it kind of actually pulls the fluid out of the vagina and makes it more dry. So this thing is that it's supposed to be really soothing, really comforting, can actually cause significant irritation. And it's more likely to cause that irritation when the vagina is thinner. And so I know this is a really busy slide here, but I just wanted to highlight a couple of things. And I tried to do that with some arrows. So just what I wanted to first point out is that some of the most commercially available products like Astroglide, Replens, KY, Refresh are really high osmolality products. And the problem with that is that it's the things that we're probably most likely to use may be irritating our vaginas. And so I think that this slide is really nice, and I hope you have a chance to look at it because it does kind of show you some of the products that are in this red box. And the WHO actually recommends that the osmolality of this personal lubricant should not really go beyond that. And so you're going to see a lot of products that are more vagina healthy or more directed towards sensitive vaginas that may be better lubricants. And you probably have seen some of these, right? Yes, Good Clean Love, Joe personal lubricant, like those are some of my favorites, and they're just less irritating. So I would definitely focus on or look to those if you're using a lubricant. And if you're using some of these other things that may be more irritating, it could potentially be exacerbating some of your symptoms. Next slide. An equally busy slide, worse slides. You guys should have helped me not have all these busy slides. I'm just kidding. But again, I just wanted to really focus again on the pH. And the pH is, we don't think the pH is nearly as important as the osmolality when it comes to tissue irritation. But if you think about what the normal vaginal pH is, you probably should be using a lubricant or a moisturizer that's kind of similar. So normal vagina is 3.8 to 4.5. The other thing that's really important here is that anal lubricants or rectal lubricants are much higher pH than vaginal. So you actually have to use different, or you should use different lubricants if you're either engaging in anal intercourse or doing any rectal stimulation for like pelvic floor PT. So just some things to think about whenever you're purchasing these products. Next slide. Again, these are some of our favorites. You probably have seen them on the market. The Joe is kind of cool because it's a water-based lubricant, but it has some silicone powder, so it lasts a little longer. One of the things we see with water-based lubricants is they just don't last as long. So the other thing to kind of keep in mind is that lubricants and moisturizers are different. Lubricants are going to be kind of, we think of it as more use per experience. So whether that's intercourse or PT, and then moisturizers are really more designed to be like a longer lasting everyday. Now, if you see how it's prescribed, like Replens, which I know is high osmolality, there are different ones out there, but it is a little glycoprotein that sticks to the wall of the vagina. It helps lubricate the vagina and keep it more like mobile, I guess, rubbing against the tissue. It's not going to be as irritating, but it's typically recommended to use 2 to 3 times a week. I have patients who have really severe symptoms. In some patients, they really love the Replens, and they may use this daily and then add lubricants to it. So you kind of layer them. So you would never just use a moisturizer as your sexual lubricant because it wouldn't do the same thing. It wouldn't have the same effect. Next slide. One thing that I just also want to point out, and the reason I brought up that osmolality, is that oils aren't dissolved in anything, so they don't have an osmolality. And you probably have heard a lot of us say, use coconut oil, olive oil, avocado oil. And the thing is, while they don't typically tend to be irritating to patients, and you may be using them with regularity, both in and outside of the vagina, there is not a bunch of data on safety with this. And one thing that's been suggested, but I haven't seen any evidence of it either clinically or in the literature, but it can, when you have these actual oils, they can create a biofilm inside the vagina that could potentially harbor bacteria, and so not let it escape. So I think it's one of those potential, should we be using the oils as vaginal moisturizers? I think the jury is still out, and I think that that's something we're going to really have to look to the literature in the next few years, and hopefully someone is kind of looking at that, because what we certainly don't want to do is make something worse by creating an environment where bacteria could get trapped in like a film inside the vagina. So I know the other thing, and I'm not going to spend too much time here on hormone therapy, but I think it's something that what we see, especially with the vagina, is that it really does respond well to hormone therapy. So certainly lubricants and moisturizers are going to be first line, but we can move to the next slide. The primary treatment, if you're going to go to your provider and you're still having symptoms, is going to be estrogen. And this is going to be typically in the topical, so just directed to the vagina. And most menopausal symptoms related to atrophy really respond well to local estrogen therapy. So that means it's not absorbed systemically, and it can be in a whole bunch of different forms, right? Gels, creams, ovules, tablets, rings, and most of them are incredibly safe. There are some super low dose tablets that even some patients who have a history of hormone sensitive breast cancer may be candidates to use. But the thing that's really steps out is that local estrogen far exceeds any placebo trials in look at treating genital atrophy. You guys also may have heard of intrarosa. So this is going to be that DHEA. And there's not a ton of data. So all the data that they have on this is really short-term studies with small numbers of patients. It seems to be really safe. The lining of the uterus does not seem to be affected with this. It can be very helpful for lubricating the vagina. It does do something very similar to the vagina with making this estrogen-like effect. There is some evidence that it may also be effective on libido reduction. So there is some systemic absorption. And they also say that part of the libido increase may be from its action on the local nerve endings, but there's still people who are looking into that more closely. What about if I can't use estrogen, right? Hormone positive, breast cancer specifically, we see a lot of those patients. And this is something that can be kind of difficult to treat. So if you are on an aromatase inhibitor, there has been some studies looking at the use of testosterone therapy in the vagina. Like the study I'm speaking to is a really short 4-week study where they looked at testosterone vaginal use, and it did thicken the vagina in women who were postmenopausal, breast cancer survivors, who are also on an aromatase inhibitor. And that's important. So that's going to be like your tamoxifen, and that's going to block the ability of testosterone to convert to estrogen. So you would have to be on that to qualify for this, but that would be an option for you. And then finally, are there any other options available? I'm just going to point out a few. One of them is probiotics. Very little data. So I think the idea is that you're going to take these oral or vaginal probiotics and you're going to just establish this physiologic, wonderful microbiome. And there's really not a lot of evidence for that. So yes, we love the idea of maybe if we change the environment and bacteria, it may help estrogenize. There's really no data for that. And then there are some small studies, just kind of moving forward, is in fennel cream. So you can have a compounded 5% fennel cream, a really small but impactful study saying that was a short course of treatment is helpful for that. Vitamin E capsules or suppositories may be helpful. Again, that coconut, olive, avocado oil of your choice. I mean, most of them are incredibly safe. And then there's been also a small study looking at zinc specifically containing vaginal moisturizer gel that was helpful in vaginal dryness in women who are postmenopausal. So there are options out there and you can be creative. And I think the most important thing too is that layering these, right? So if you don't get full relief with one of them, then you add another and you add another. The other thing you see us do is that you increase the frequency. So that's the same thing with estrogen. Oftentimes we will bulk dose the estrogen at the front of your treatment. And you would take, you do estrogen cream for 14 days, and then you would do it 2 to 3 times a week. But in the same thing, you would shorten the interval of use with the moisturizers and the lubricants, and really be creative and find a treatment that works for you and also doesn't exacerbate or irritate any other symptoms. One of the other things, and I'm just going to put a plug out here, is that one thing we have noticed in women, I say we as science, is using the vagina can also be helpful. So arousal, stimulation, orgasm increases blood flow into the pelvis. You could certainly do that just with external stimulation, no penetration necessary, just to get that good, healthy blood flow into the tissue, because the vagina is and I've never heard this term until recently, it's a microcirculation. So it basically kind of decreases the amount of blood flow to the vagina until you increase it with arousal or orgasm. And so I thought that was really interesting. And we do notice that women who use the vagina more often actually have fewer GSM complaints. So I think it's something that many women who are like having pain right now are saying that's not an option, but it's something that may be beneficial, and you could explore that. So in conclusion, this is incredibly, incredibly common, and you may not even know that some of your symptoms are due to this disorder. There's a lot of options that are available. You could certainly go beyond what I've shown you here and explore, but just kind of keep in mind that osmolality and pH as you do that. And then we know that combination of treatment seems to have the best outcomes.
Thank you. Thank you so much, Dr. Carey, Dr. Louie. There was so much in that, oh my gosh, thank you so much for providing all of that information. We do have a number of questions that I would like to just start, and then whoever can respond, that would be great. A couple that came in just for clarification. Is Replens available over the counter?
Yes, it is.
Super. And then I know you talked quite a bit about the estrogen creams, but can you clarify just one thing? Should estrogen creams be used regularly, long-term, or only when engaged in sexual relations?
Great question, because I have patients who will use the estrogen and they will feel better, and then they will stop using it. And it's one of those lifelong commitments. I know we don't make too many of those, but it really, if it is helpful, then you would need to continue to use the estrogen therapy, typically twice a week, just at night, not before intercourse, just kind of on a night where, patients often will pick like a Sunday and Wednesday, and they just have a little star in their calendar, and that's when they do the estrogen cream at night. But it really is something that we, you make that commitment to, and if you stop it, your vagina will go back to a less estrogenic state. But great question. I did not clarify that.
Okay, thank you. Thank you. Can you talk a little bit about how you would address the diminishment of sexual sensation after menopause?
That's a tough one. I mean, I can speak a little, and I would have Louis speak to it too. So I think we may have different takes on it. I think so. Sensation. I mean, it could be a local tissue issue, right? Like if you had, less elasticity of the vagina, or weren't, it could be a medication that you're using. It could be just, you may not be as sensitive or interested because you have a decreased libido. I've had some patients who say, you know, I just don't I don't feel as much, right? Even if it's not a medication or a tissue and that's where I'd say two things. I would say, you know, sexual therapy can be really helpful because it can help kind of reframe just in general sexual changes as we age and how to adapt to them. The other thing I would say, if it's truly just a sensation with intercourse, this is where if you aren't using and like an external vibrator for clitoral stimulation, that's the time to add it. So if you were able to be, you know, aroused in orgasm without assistance and with just penetrative intercourse or oral or you know, I'm not making people too uncomfortable, but like all of those, you know, kind of manual stimulation, then this is a time to really add like a more powerful external vibrator that you could just hold during intercourse or with foreplay, and that may make the sensation more maybe easier to feel. The ability to orgasm does not decrease with age.
Yeah, I would absolutely agree with Dr. Carey. I think that those are some other things that physical therapy of the pelvic floor may be helpful for. You know, if intercourse is too painful to have regularly because of pelvic floor spasm or because of dryness, and you're starting those treatments, but you're not really prepared to have regular penetrating intercourse or vaginal intercourse, physical therapy is a good way to draw extra blood flow to the pelvic floor muscles, which helps to increase sensation and tone. And both of those things can make sex more pleasurable.
Thank you. Thank you. I think that was really helpful. Is a decrease in sexual desire normal after menopause, and why is that?
So first of all, great question, and it's absolutely normal. And I'm going to say that with a pause, because if you think of the biology of females, right, we are like this, the libido is really designed for procreation, if you're going to break it down to like the basics. And so understandably and naturally with menopause, the ability to reproduce decreases. And so the estrogen and the hormones drop and libido drops. That, I think the term sexual dysfunction is so that's normal. Sexual dysfunction is when that is distressing to one or both partners. And that's when you need to address it. So it is normal. And I have many patients who come to me and they say, I feel like I should be having sex, but you know, my partner's ill. I'm not really interested. We have great intimacy. Our relationship is strong, but they feel like they're doing something wrong. And I think that that's where I would really reassure people is that that's okay. And if it's distressing for you and or your partner, then it's a time that we would want to direct and try to identify things to increase desire. The only other thing I would say to that is it is difficult to increase that just lust desire, like when you have low hormones, but and I would say this, but arousal and orgasm, like the ability to achieve those should be the same, even if you aren't like wanting to attack your partner, right? But one thing that can be really helpful is if you start arousal, if you start stimulation, touching, libido can often follow. And that sounds a little backwards because it is. So that's the thing I do counsel my patients on is like, sometimes you have to do things a little backwards. And then you're like, oh, I do like this. Oh, that does feel good. You know, and then you just have to kind of reformat the way you approach it.
Oh, you guys are great. I agree. All right, here's another question. Confused about lubricants versus moisturizers. When are they used and which should be low osmolality?
Yep. So moisturizers are going to be used regularly. So like 2 to 3 times a week. Sunday, Wednesday, you use your moisturizer. Lubricants are really going to be with penetration. So you do your PT, you have intercourse, Some people even say like exercise is really dry. And so some people will use lubricant before they go on their walk. And you just put a panty liner on because you might have some discharge, and then you're able to do some of the things that you want to do. And then both of them should be low osmolality if that works for you. Now, if you're like, I've been using Replens and Refresh and KY and I feel great, then you probably don't need to change anything, right? I mean, those are the things too. It's only if you don't feel great, we would recommend that you stay in the lower. And you can use all of them. I see another thing. You can use a moisturizer, lubricant, estrogen. You use them all. And I would just say,
yeah, it's a good message. I think of moisturizer as like moisturizing the rest of your skin, right? So like, you moisturize your face, you moisturize your hands. The vagina is just another part of our body that has skin. And we don't talk about it because we think it's sensitive and taboo and private, but like the reality is we all have a vagina. It's susceptible to the aging process as the rest of our body is. And so it's just as important to moisturize it regularly, like you would do your knees or your ankles. And the lubrication is the thing that I would recommend for anything that's sort of inserting into the vagina, where you feel like that may cause additional discomfort above and beyond like your average everyday activity. So you can use them both because they have different purposes, and that's okay. They're not going to interact or cause a problem by using those multiple different things because they just have different purposes.
Yeah, I think that's really helpful to clarify, because I think some people are worried that you're just going to overdo it and maybe they'll interact or cause an infection or, so sometimes less is better, but I hear you.
Yeah. And if you ever have any questions about what might interact or what's going to be a problem, you can always contact your doctor, set up an appointment with us or send us a message.
I have, there's a lot of questions. Okay. Which is better for preventing bacteria in the vagina, cotton panties or the new technical fabrics?
We typically recommend that our patients stay away from anything that's non-breathable, right? So maybe I'm just not hip enough to know what they like the drying fabrics, maybe with exercise, but I think a good cotton underwear is the least irritating to the vulva. And if you have a lot of irritation, you can certainly use like a barrier cream with your underwear, or if you have urinary incontinence and you wear a pad, you can use like Vaseline or something, or coconut oil every day, and then sleep without underwear at night is what I recommend with my patients. So you should just be wear a nightgown and just take your underwear off and really not keep everything kind of closed up.
I want to be conscious of everybody's time. So there was one other question, and we'll make this the last question before we wrap up. How do people make a pelvic floor appointment? Do you need to see a specialist? Do you have to see a doctor first? How does somebody go about doing that? What is the best order?
Most physical therapy centers, if you know of a pelvic health center close to you and you want to go there, most of them will require a referral from a physician. It can be any physician, doesn't have to be a gynecologist, doesn't have to be Dr. Carey or I. We are happy to do that. But most primary care physicians can also write that referral. We just want to make sure that your correct diagnosis is in the referral, because as we talked about, there are two different kinds of physical therapy. One is a tightening and one is a relaxation. And you really want to be sure that you're going in for the right one. So oftentimes the reason why they require a referral is because they really do want someone who knows what they're doing to make a correct assessment of the pelvic floor and then be able to send you to the right kind of physical therapy. So if you have any doubts, if you don't have a previous diagnosis, or a previous exam from a specialist, you may want to see a gynecologist who specializes in pelvic floor disorders, like myself or Dr. Carey, or someone who's local. And if there's any specific questions, people can reach out to us and we can try to give you some specific recommendations for specialty providers that may be in closer to your area. I know that UNC is not always convenient for everyone, but we do have virtual appointments, as Dr. Carey said. So we're happy to sort of talk through some of those options. So most physical therapists will want a referral, and that's just because they want to make sure that they're treating the right thing, and that, you know, if you're going for painful intercourse, that it's, you know, not because things are too tight or because you have prolapse. They just want to make sure that they're doing the right exercises with you.
And patients don't need, they can make an appointment directly with you, correct?
Correct. Yes. You don't need a referral to see Dr. Carey or I, or anyone in our practice. We also work with 2 other specialists. And so there's 4 of us with 2 fellows. There's 6 providers. We'll be able to happily accommodate you, and you don't need a referral.
Great. Thank you so much, both of you, for taking your time today. Like you mentioned, a lot of women don't talk about these issues. And so being able to provide a non-judgmental, safe space to provide this kind of information is just really, really wonderful. So I just want to make sure everybody on the call knows that this session was recorded. You will be getting an email to direct you to that, as well as you'll have access to these resources. If you are interested in learning more about Dr. Carey's work, Dr. Louie's work, any information, please contact me directly. And one more thing before you go, please fill out the questionnaire, because that will help us plan for other events like tonight. So thank you to everybody who participated, and I hope to see everybody in person at some point. Thank you again.